Rajendra Prasad, Dr. Jagdish Rana, Dr. Gadre, Dr. Sudhang Bharti, Dr. Vavikar, Dr. Anurag Mishra, Dr. Mayuri Kamar, Dr. Dhami, Dr. Sanjay Chaudhary, Dr. Suresh Kumar. All of you, thank you so much. Thank you. I'm going to check whether all the speakers are there. Dr. Arvind Maurya, Dr. Alok Sati, Dr. Hirika, Dr. Prasanna Venkatesh, Dr. Ankit Agarwal, Dr. Jitendra, so all have yet to come. Dr. Prashant Girish, not here. Dr. Pratik, Dr. Sanjay, speakers in the Surgical Innovators Corner session. And we are going to start the session 2. Just for an information, we do not have 4 of the speakers who have joined in yet. So maybe some of the judges might find themselves in a loose end. We'll work it out. I'll call upon our first speaker. And by the way, the duration of the talk is 4 minutes and the discussion is 1 minute. But if the speakers initially, we may take the discussion to 2 minutes because some of the speakers are not there. So I invite Dr. Arvind Kumar Maurya, who is going to be talking on terminal chop, a novel technique in hard cataracts.
In this film, we aim to demonstrate. Play from start. Greetings, everyone. In this film, we aim to demonstrate our new innovative surgical technique. Greetings, everyone. In this film, we aim to demonstrate our new innovative surgical technique using advanced terminator chopper for chopping of mature hard cataracts. We have no financial interest. The rock hard cataracts are always difficult to crack as being stronger in compression but weaker in tensile strength. It is always difficult to crack them with present chopping techniques and instruments with chances of many well-known complications. But according to mechanical rock excavation system and Griffith theory of brittle fracture, it is always difficult to crush, incise, sculpt and segment in these hard rocks with compressive forces, but much easier to break and crack inside out dispersive mechanical forces. Breaking and cracking is much easier when mechanical forces are applied at the open edge on maximal weak points in form of micro notch or micro grooves at the surface of any hard material. So, there are many specialized West tools available which are pushed in the natural or the drilled grooves with the help of blunt hammer-like objects leads to crack these hard rocks under tension and complete split is achieved in no time. Terminal chop is a new surgical technique developed by Dr. Rajendra Prasad, works on the principle of secondary rock breakage system with concentrated dispersive forces to crack these unbreakable hard nuclei. In this technique, similar to cracking and breaking these solid hard rocks, a unique inside-out dispersive mechanical forces are created to initiate a full thickness crack at the weakest soft thin equator, which simply traverses into the entire nucleus, breaking it into 2 complete pieces. Mechanics of terminal chop initiate a tensile fracture in a more direct manner from the equator parallel to the nuclear surface in a very efficient, least manipulative and minimal use of phaco forces. Unlike in the vertical and horizontal chopping utilizing high compressive forces with high stress in these type of hard nuclei. So, there is a specially designed advanced terminator chopper developed by Dr. Rajendra Prasad with blunt olive tip to safely hook, hold and stabilize and then initiate a crack at the equator of the nuclei. The mode of action of terminator chopper is similar to drag tool, generating stress at the site of initial groove in the direction of the equator on the other side, parallel to the nuclear surface to create a tensile fracture and divides hard nuclei into two complete segments. In this new innovative surgical technique, both the phacoprobe and the advanced terminator chopper are always parallel to the iris plane as compared to the other chopping techniques like the vertical and the horizontal chop. Thank you so very much.
So it's a nice technique. We are seeing it for the last 2-3 years. So in case of a small people, yesterday we saw a, a chopper, so which was working very well in a small people. So many a times we encounter small people. So does it work in the small people with heart cataract?
Yeah, then we need to use the people expanders. Then we can use it.
So if we use viscoelastic, just viscoelastic for stretching the pupil, it will
Yeah,
not
if
work.
viscomatrices work, the cohesive, sometimes it works very well. Yes, of course we can go for that. But if the dilatation is still not good, we need to opt for the pupil
Because you have to
expander.
go to the equator.
Yeah, we have to go to. That's why. So we need to use the pupil expanders. BHAX is very means that can be easily implanted and it gives a very good dilatation.
Okay. Uh, Thank you very much. Any other questions from the judges, or we can move to the next speaker is Dr. Alok Sati. Dr. Alok will be discussing on the sutureless femto laser. Judges? The, you want to? Yeah.
No, no, we have just 1 minute time.
That's okay. In case if you want to ask quickly, you can always pitch in. The two
Yeah.
judges we should allow.
We don't have, we are stuck with time.
Yes, please.
Yeah. So he'll be speaking on the sutureless femtosecond laser assisted DALK, an innovative technique, and request Dr. Dhami sir to please be a discussant for this. And if Dr.
A
Anurag
very
wants to ask any
warm
question,
greeting
it's
from
free
our
to ask.
institute. The topic is sutureless femtosecond laser assisted deep anterior laminar keratoplasty, an innovative technique. Traditionally, we all know that the DALK has been performed by manual method, by big bubble method, and femtosecond laser method using sutures. So the issues with traditional techniques are twofold. One, the suture-related complications, and second is the long intraoperative time. So how to circumvent these? So we thought, can we have a sutureless technique in DALK? Can we not put the sutures? But the main problem was whether there will be a stable apposition between donor and host cornea in this technique. So we thought of doing it. We took first patient, and if you look at the depth of the opacities to the tune of 465 micron with the minimal corneal thickness as 515. This is the donor preparation. When we did the donor preparation in femtosecond laser, the diameter we took at 7.5 with total thickness as 485 micron, because we take 20 micron more than the expected depth in the recipient cornea because of detergence effect post-op. And the energy we took at 40. Now this is the donor tissue preparation. We first place it onto the this is a special type of Catina artificial chambers, and then this is the docking process which is going on in the femtosecond laser machine, that is Visumax machine, no financial interest. And this is the laser delivery into the donor tissue. And here you see there's a side cut. And this is a beautiful lenticule that we are deriving now from the cadaveric cornea. So this is the lenticule which we are going to implant, but you can appreciate that this is a very thick lenticule because in DALK we have to go quite closer to the Descemet membrane. Now the recipient cornea, again the diameter we have taken as same as 7.5, but the thickness is 465 micron with energy setting as 40. So this is the recipient preparation. This is the, you can appreciate the corneal scar in the cornea. And this is the laser delivery after docking in the Visumax laser system. And this is the side cut. And now this is the recipient cornea. Now you can appreciate that we have gone very close to the descemet membrane. Ideally in this situation, what we do after placing the donor cornea, we put the sutures, but here we have avoided that and we have seen whether it really works because we are going quite close to the descemet membrane. And this is, you can very well appreciate a very firm apposition, a very nice apposition here. Though we have used the fibrin glue to make it oppose instead of using the sutures. Followed by placement of the bandage contact lens. So this is the post-op day 1, 7, 30 and 6 months. This is the post-op photograph on OCT. You can appreciate that we have gone almost to the tune of, to the depth of descemet membrane with 465 micron that we are expecting. The specular findings, we have found no significant changes, and till date we have done about 15 such cases with outcome as pre-op vision. If you compare, there is definitely a significant change in mean BCVA. Astigmatism is to the tune of 2.1 and with nil complications. So the question arises, is it really a DALC? Yes, we are approaching almost near 50 micron to DM. What about the edge effect? How the edges, this is the edge effect you can see. There's a beautiful apposition, no overriding or underriding. How strong is the apposition? So we have performed phacoemulsification with normal parameter in 3 of such patients, and we haven't found any popping effect in the graft. So it's a promising technique. Definitely it has the ability to change the practice pattern. And of course, we require a large cohort to conclude our results. Thank you.
Very nice. I'm not discussing, but don't you think your set of patients from Chitrakoot, would they be careful enough not to rub eyes? Because in refractive surgery, if you have a free flap, we are able to put it back and place a BCL, and we've never had lost flaps in those
So here,
days.
ma'am, the counseling is very important.
Yeah.
I think the counseling plays a very important role.
Yes, Dr. Dham.
Look, it seems beautiful, well done. But my question is, what is the learning curve?
Learning curve is very less, sir, in this, because if you look at it's a basically machine work.
There it is.
It's a machine work, but yes, follow-up is very important, because what ma'am was telling that they should not unnecessarily problem in post-op duration. That's very important. Secondly, we have also seen at 6 months we have performed phacoemulsification 3 of the patients, and normally we think that the apposition is not great, but here we haven't seen any popping off effect of this, so there has been apposition also.
How is the epithelial defects? Do they occur, heal, or better?
We put
That's the only complication we fear.
We put the bandage contact lens at post-op, so epithelial defect we haven't encountered.
When do you remove the bandage?
3 weeks post-op, sir. This is a normal protocol which we have set.
You showed a good laser passing through a thick scar. Are you sure it does, or you increase the energy?
Yes, we have to increase the energy. Normal if you look at the femtosecond laser procedure that we do, like SMILE and other, it's 28. 28 means 28 into 5 nanojoules. But here we have increased to 40 nanojoules.
That's one
Sorry,
point
40,
which doubts us.
Yeah,
Laser passing through a scar tissue. Second is the most common, the least told, and always never asked for is the suction break. Whether it's a donor eye or a patient's eye.
Suction, sir?
The breaks. The patient is non-cooperative and the suction breaks during.
Yeah, suction loss that we call, it's very, it's not common because I have been doing even the smile for a long time. So I have encountered in 2-3 patients. So again, the pre-operative counseling is very important, sir, for avoiding the suction
Because
loss.
this patient is unable to fix, he already has a bad cornea and you have only one fixing light in this kind of
But
laser.
with my experience of doing 15 such cases, I haven't encountered any suction loss with it, sir. And I know what you're talking about. You're saying that since there's a scarring, so suction loss will be an issue. But
And it's an
one
irregular
is-
cornea.
yeah, but it hasn't happened, sir, because you have to keep telling the patient when you are, when you are taking the dock, when you are docking the thing, you have to keep telling, okay, B center. Then we have a system where we can see through infrared, right, that whether there is a centration or not.
That is there.
That is
Yeah,
there.
basically, because of the poor vision, he says there could be a
Yeah.
suction break, but you can keep the attention of them
Attention of
totally
the patient.
grasped. Because
And
it's,
we can keep telling them, okay, look straight. That's
Yeah.
one. And secondly, we can observe onto that infrared
Yeah. No, it's
system also.
Definitely this innovation is not for all. That's sure.
Yeah, but it has to be there, sir, because otherwise our country will be lagging behind.
Thank you. Anyway, very good work. Thank you.
no, besides the suture related issues are totally obviated.
Obviated.
So that's
and
a
it has
wonderful
worked
thing.
really work because
Yeah.
when you can do cataract through femtosecond laser.
When
not
did you do the
this?
cataract surgery after doing this? Like
6
3
months.
6 months.
Yeah.
Yeah.
6 months.
I think that's innovative.
All these cases over the years have no complications such as infection or
No infections, because in our protocol, it's very strict because we are spending money on such patients and we are keeping them regular follow-up. If any patient doesn't come well in time, I inform them personally because they are not many, they are limited patients, say 15 only, so we can very well take control of them.
Thank you, sir. Thank you very much. We'll move ahead with the next. Dr. Hirika Gosalia is not there, and Dr. Prasanna Venkatesh is not yet arrived. Are they there? No. So we'll move on to Dr. Ankit Agarwal. He'll be speaking on the low-cost wide field OCT, and I request Dr. Anurag Mishra to please be the discussant for this case.
Good morning and thank you ARC for giving me this opportunity. We know that OCT is now a day-to-day tool for most of the practitioners. Even a single practitioner in a private OPD has a OCT installed. It's like a slit lamp for us now. We use it for screening of various retinal and macular disorders like optic disc edemas, or glaucomas, macular edemas, etc. The most commonly used OCTs are the spectral domain OCTs, but the newer ones are SSOCTs. The spectral domain OCTs had a very strong problem that only a 6 mm or a maximum of 9 mm of scan area was there, while the newer OCTs can take scans up to 12 mm, and there are some wide field OCTs now which are there, they can take up to 18 mm. Thus, the lesions extensions of edema in spectral domain OCTs, it was very difficult to know. For example, in a CSR, huge CSR, the boundaries of which cannot be known in a single scan. And what happens is that many a times we get our assistants to do the OCT. We don't do it ourselves. So we just see the reports. And when the report comes to us, we cannot distinguish clearly that whether it's a CSR or it's a shallow RD. Also, if perimacular PCV, BRVO, extension of a BRVO, we cannot know. To overcome this, we propose a low-cost technique to increase the scan length. Thus, it will be able to scan most of the area within the vascular arcades in a single scan. For this, we took 10 patients with various indications for OCT screening and did their OCT with 2 methods. First, a macular scan was performed without the device in front of the eyes. A normal OCT scan length of 6 mm, which is default in my machine, which I am using for this study, that is TOP1 Maestro 1 was used. The image was obtained and another scan was taken, for which I took +20 diopter dual aspheric glasses. I made the patient wear them, and the glasses had a back string attached so that the glasses are firmly placed in front of the eyes. And the OCT was taken with the patient wearing these glasses. This is how the patient sits in front of the OCT wearing the glasses. And these are the glasses which I used. Now, the scan length of the OCTs which were done with wearing the glasses increased by proportion of approximately 1.5 times the scan length without the glasses. Now, in a normal fovea, a normal macula, in a ametropic individual, the optic is to fovea distance is about 4 to 4.5 millimeters. Thus, the scan length with the spectacles covered the area almost all within the vascular arcade in a single radial scan. This is the descriptive diagram how much area is covered using the single radial scan. This above part is the scan with the glasses. Now, an example of OCT is taken. In this patient, we can see that with plus 20 diopter spectacles, a large scan was taken, while without spectacles, only a smaller area was covered. In the case of BRVO, we can see the extension of edema much more than without the spectacle. In an NPDR, we can see that outside the scan area also there are some hard exudates present, which can be seen with the OCT. The optics are that the aspheric 20 diopter glasses, they condense the light rays, and thus a wider field of area is obtained. The patients who underwent OCT with plus 20D spectacles had an increased scan length as compared to those without spectacles. This helps in screening of patients of dioptry-retinopathy, BRVO, etc. for lesions in the peri-scan area and the perimacular area. The limitations are that this has only been tested on my Topcon Maestro 1. However, basic optics are same for any OCT, so should work in any. But the problem is that the parameters of macular thickness, the RNFL screening, etc., which are done by the OCT software, will not be holding true in this because the OCT software is not configured for this optical change. This innovation helps increase the field of imaging and thus can capture perimacular areas which might have been missed earlier in a single scan without the need for investing a large sum of money on a new OCT with a wider field of area. The cost of these glasses is hardly 1,000 rupees. Thank you.
So that's a nice little bit of innovation that you brought in there. But there are a couple of things that are lurking in my mind, and I can't help asking you. Number one is you probably have not documented what sort of area has been scanned with your technique vis-a-vis the normal wide field OCTs we already have in the market. There should be a comparison. I mean, you have to document it.
So that's because it's a single center study. We did it in a private center. We don't have access to a wide field OCT as of now.
No, you can go theoretical. You can go what they promise and compare it with what, because it's very difficult to document what area exactly are you scanning, because the pictures honestly did not show us much. So we have to see exactly what area they're scanning. The other thing is,
so what I did was that in the OCTs, when the vascular arcades are scanned, we can see the vessels on the OCT scan. So in few of the OCTs, I could see the vascular arcades in my scan with the glasses. But without the glasses, when I'm doing the scan, I could not see the vascular arcades in the OCT scan.
that's exactly what I'm saying. Essentially, what you're doing is you are minimizing the magnification that happens at the retina end.
Yes.
Because this machine is not tailor-made to be working with a wide field thing. The beam is the same, right? The concentration of the beam is the same. So since you are compressing it, it is scanning a wider area.
Yes, sir.
Since the machine is not tailor-made to do this job, perhaps it is better to compare it head-to-head with the machines that are already tailor-made to do this job.
I'm already in talks with Qubits actually for this, and they have requested me to send you all the data with this, and they are saying that in their next iteration, they will give this as a standard accessory so that a wider field of area can be taken. A wider field of area can be taken if a doctor requires. So I've talked to them once. I'll try to finish this research project.
Yeah, so that's what I'm saying. You have to increase your sample size, and also the fact that since you are placing such a high-powered plus lens in front of the eye, there might be a possibility of artifact because the light rays traveling through such a high-powered lens
That's true,
might
sir.
just...
The signal strength reduces a bit. We can overcome this by using high-index glasses, so which are thinner and have less aberration also. And this needs
and make sure they're perfectly fit, because slight bit of even a millimeter's displacement in front of the eye can have a prismatic effect as well, which will bend the light rays again.
True. That's why we have put the strings behind and we make it tight so that it does not move with the patient's movements and all. We're trying it, but there's still some research is required in this, sir.
Thank you. Good job.
Thank you, sir.
Yes, yes, yes. Not, don't have time on the stage, it has to be done on the side. Next speaker to come.
Thank you, Ankit. Thank you, Dr. Anurag, sir, for that wonderful discussion. I next call upon our next speaker, Dr. Jitendra Jethani, a very senior colleague and a good friend. So he'll be presenting on the prism holding device, and I request Dr. Madhukar Reddy, sir, to please be the discussant for this case. Oh, he has bought some practical this thing also for us.
Be shown afterwards, this is bribe.
I'm just showing you can use it and see what I'm trying to
Okay.
show. So,
Even for the moderators also. Yeah.
good morning, everybody. Yeah, respected judges and respected teachers. I would be speaking on a device which we have made for measuring large angle strabismus. We know that, in India, at least patient comes late to strabismologist, and large angle strabismus is quite common in India. We all have seen big angles. And what happens when you are measuring large angle, in your prism set, you only have a 50 prism, not more than 50 prism. So what you need basically, like I will show you this small video. What you need basically is that you need to split the prisms, and one person has to hold the prism, either your assistant, you obviously cannot do it because if you hold the prisms, you cannot do the cover test. So some assistant will be holding the prisms. They may not be maintaining the frontal position. You need a assistant, and if you have to measure hyper, you need another prism. So what we thought was that we need a solution to this daily problem that we have. So what we did was we took a stick, we put a plate on it, and it has a adjustable section. We will see the video of that. This is how the patient will hold the. It's not a very very high tech device. It's just a more of a common sense kind of device. What we have done is we have taken a stick. Patient is holding the stick. So this was the first prototype which we made in aluminum, then we made it in steel, then we finally made it in wood because it has to be lightweight. So this is the first prototype, and I will be showing the final prototype. So this is the prototype which we are currently using. Yeah, so if it runs, video is not running.
No, please play it. Click on it. Acha, it's taking time.
It's taking time, so we are a little too quick in the pressure of time. So, so basically the device has a central stick, has two holders. You can move the holders because if you have esotropia, you have to bring the two holders close. If there is exotropia, you have to bring them out. There's a small screw here. You can tighten it so that it stabilizes in the position. You can take out the prism. The same holder fits for vertical prism as well as for horizontal prism. Should we reload the presentation? It's not, the video is not working. So basically, you can move it. You can take two prisms. I think we've made the point what we wanted to make.
Yes, you have.
We can. This is basically, and then I have the more of details of what we did. We tried to use it in almost 100 patients in the OPD. We found a good correlation with the existing method of holding the patient. Somebody is holding, and we are using a prism holding device. It has actually a lot of usefulness for people who are doing strabismus, because if you want to measure AC by A ratio, you can put another flipper on it. You can use plus 2.5 diopter lens and do an AC by A ratio. Two horizontal prisms and another vertical prism you can hold. So it has a lot of utility for us because patient is holding the device. Now your both the hands are free. You can use accommodative target. You can do the cover test. So it's quite useful for us in day-to-day practice. So that's it. I think, yeah. The presentation has got smitten with the device. I think we can, if there are any questions, we can.
Yes, doctor. No, you have conveyed it well.
Yeah, it's a very convenient and very common sense contraption to use.
Yeah, so this is just to, I think, yeah, we can discuss, sir, if it is. If there are any questions, we can take questions.
Any more comments from other judges, audience?
No comments. we would try to make it commercially, but we have not patented it because the cost of patent would be higher than the amount we will generate. At this point of time, we have around 1,000 pediatric ophthalmologists. We won't be able to sell more than 2,000 devices. So we thought that it would be better that we don't patent, make 2,000 devices and give it to pediatric ophthalmologists.
That's a great,
Much
great
easier that
idea.
way.
Very
Great
nice,
idea.
very nice. Yeah,
Very nice.
thank you very much. We go on to our next speaker. Thank you. Next speaker is Prateek Nishant. And we have Dr. Jagdish Rana as a discussant, and the topic is vectoral analysis of iris photographs for assessment of ocular torsion in cyclovertical strabismus.
So good morning, all. Thank you for the opportunity, ma'am. And so the diagnosis of torsional strabismus is not always straightforward, and the current standard for quantitative assessment of the disc is the disc fovea angle as measured on fundus photography. Recently, distinctive iris features are being used in a variety of applications to measure the torsional change. And a need was felt to develop a simple, non-invasive, and affordable technique to measure the change in ocular torsion using readily available consumer-grade DSLR camera and PC software for capturing and analyzing the iris photographs. This is the first known study to capture binocular iris photographs in Indian eyes. So previous studies, as seen in this review of literature, entail mydriasis, time delay, increased costs, inconvenience in uncooperative children, and in those with hazy media. There's a described effect and methods of correction of head tilt also, and the change in ocular surgery with ocular torsion with surgery is different as regards the objective measurements and the subjective measurements. So the lacuna that we found was that there is paucity of binocular photographic studies and none have been done in Indian eyes. So there is a need to develop a simple, low-cost, non-invasive technique and to validate and test its accuracy. These are the objectives. In particular, the secondary objective was to compare the accuracy of this measurement with the standard technique. And but before that, we needed to develop the method of binocularized photography using the DSLR camera and to define the photography settings thereof. So this was a one-year prospective comparative experimental study amongst subjects more than 8 years of age with diagnosed cyclovertical strabismus. Uncooperative, unwilling subjects or those with ophthalmic pathology precluding imaging were excluded. So 30 eyes of 15 such patients were pre and post-operatively assessed, and difference in torsion was found using the two methods. This is how the photographic method works. So the photos were taken in a dark room with the patient seated erect. The face was perpendicular to the floor, parallel to the wall behind. Frankfurt lines were parallel to the floor. Residual head tilt was minimized using a spirit level at the patient's forehead. And the camera was tripod mounted with the lens level with the patient's eyes. Two flashlights were directed from 45 degrees inferotemporally as seen in the figure. Equipment and settings were as shown during photography. The head tilt was minimized again, and these are the photographic settings which were found with empirical experimentation. We enhanced the images, marked the ellipses and iris landmarks, measured disc fovea angle. We read the pixel coordinates of the iris landmarks and the slopes of lines joining the pupillary centers to these iris landmarks. The iris torsion angle was calculated in Microsoft Excel using the average of 4 iris landmarks. These are the demographic characteristics. 30 eyes with various diagnoses were included, and objective X cyclotropia was seen in 10 eyes and in cyclotropia in 5 eyes. These are photos of the two methods applied to one of the cases. The absolute fundus difference and the absolute iris difference were calculated, and the difference between the two methods was derived and compared. The difference of the the distribution of the difference between the two methods was normal, as seen by Gaussian kernels, QQ plots, and Shapiroff-Wilk test. The mean difference was 0.150 degrees, as seen in this plot, and it ranges from -0.5 to +1 degrees interquartile. The two one-sided tests based on the Wells T test showed the equivalence of the two methods. Methods showed strong correlation as seen on the Spearman's correlation coefficient as well as the Bland-Altman analysis. So binocular photography represents more physiological state of cyclofusion. There's difficulty in vectorally analyzing the iris pattern for assessment of ocular torsion in patients with extremely dark iris. And only one similar report by Felius et al. In 2009 had done a preliminary assessment of feasibility of such a method in Caucasian eyes. By comparison, our study shows that in 30 eyes with various diagnoses and various surgeries, this method works with the arrangement as described. This is the first study describing the camera settings for binocular iris photography in Indian eyes. Thank you.
The discussant, Dr. Rana, you have anything to ask him?
Basically, I am not a
I
study
know.
specialist.
Yeah, yeah.
But is there any study published or any other method, standard method for this, established method for this?
So for the assessment of cyclotorsion, sir, there are objective methods and there are subjective methods. Subjective, in fact, means that the patient reports whether he's seeing a torsional strabismus or not. An objective method tells whether we are actually seeing the torsion of the eye. So there is no standard of a default value which the torsion can be quantified. We can only quantify the change in torsion pre and post surgery. So as of now, that is being done by the fundus photograph. The basic limitation of using a fundus photograph is that you can capture one eye at a time. You cannot capture binocularly. The other thing is that an element of proximal convergence occurs whenever you pose the fundus camera onto the patient. So that is one aspect which makes all these methods non-physiological. Binocular photography, by comparison with a camera that is quite far away from the patient, makes it more physiological, and therefore this method is more more practical and more accurate in the true sense.
Any international study published?
No, sir. Previously, only one study has described this method of binocular iris photography. That was in Caucasian eyes, and that compared it with the retinal photographs also. That was done in 4 eyes with inferior oblique overaction. That's all. And the photographic settings were not described. Caucasian eyes, as we know, have light iridis. There is no description of illumination used. There is no description of what magnification was used, what shutter speed was used, what was the exposure compensation. All those settings have been defined in our study.
Thank you.
Thank you so much.
Thank you, Pratik. Now we have our next speaker, Dr. Sanjay Chaudhary, sir. So he'll be speaking on the bandage contact lens scaffold for management of PCR with residual nucleus. And I request Dr. Mayuri madam to please be the discussant for this case. Over to Dr. Sanjay, sir, please.
Can you please start this?
Here? Yeah. So I request Don Sarkar to please come over to the dais on the outcomes of modified HPMC CXL in thin corneas. And I request Dr. Sanjay Gadre, sir, to
Be the discussant. Done.
Okay, Dr. Anurag also can come. Any of the judges? Okay, Madhukar sir will be the discussant. Okay.
A very good afternoon, morning to all of you. Thanks, ma'am, for giving me the opportunity. Learning is a constant evolutionary process, and every thought process having some innovations. That's why we were here from couching to the chopping. So I'll be presenting outcome of modified HMC CXL in thin cornea, but the thinnest pachymetry less than 400 microns. I have no financial interest. On introduction, keratoconus, the chronic progressive ectatic disease of the corneal stroma, characterized by progressive central or paracentral stromal thinning. Excuse me.
1 minute, please.
Excuse me. On introduction, keratoconus chronic progressive ectatic disease of the cornea, characterized by progressive central or paracentral stromal thinning and irregular astigmatism, leading to the impairment of the vision. Collagen cross-linking or CXL is a novel technique for halting the progression. Several advanced keratoconus patients present having the pachymetry less than 400 micron and the present ophthalmologist during that thickness pachymetry. So HPMC CXL is a proven procedure for thin cornea. Here we have further modified it with combined AP on and AP off technique with thinnest pachymetry less than 400 micron. So purpose of the study to evaluate the changes in the thinnest pachymetry, posterior elevation, topographic value of the HPMC CXL with combined AP on and AP off technique in progressive keratoconus patient with a pachy less than 400 micron. Associated changes in respect of the BCVA, central pachy and specular microscopy were noted. Statistical analysis were done at the pre-CXL and the post-CXL and the 6-month follow-up. So methodology, The prospective comparative interventional study included 40 eyes of 35 patients, progressive keratoconus. All patients underwent the thorough clinical examination, including the VCVA and the measurement of the topographic indices on OBSCAN and pachymetry, both the pre and post CXM at the 6 month. So inclusion criteria are age less than 40 years, documented progressive keratoconus, Pachy was less than 400 micron. Exclusion criteria: skirt corneal autoimmune disorder, corneal ectasia not caused by the keratoconus, pregnancy and lactation, and prior CXL or any other corneal surgeries. What modification we have done? CXL was performed by the same surgeon under the topical anesthesia. Here, epithelium, we maintain the epithelium at the visual axis or the thinest Pachy, remaining that zone we are maintaining the epithelium off. So it's a combined epi on and epi off, and epi off technique with the train and then followed by standard your protocol. We have followed the 10 microminute UVA exposure with 9 milliwatt per square centimeter after saturating the stroma with isotonic riboflavin solution, 0.1% solution with 1.1% HPMC as a carrier. These are the real-time picture. You can see this upper one. This is the modified one. On the just immediately on table, you can see the central islands of epithelium surrounding the mid-fairy, the epithelium of. This is immediate first post-op day and the third post-op day. And the other we are comparing this thing where entire whole thing was epi off. You can see almost it will take 48 hours. The epithelium still the epithelium defect was there. So the outcome, the primary outcome means the changes in the thickness pachymetry, average mean posterior elevation, and topographic A value as compared to the pre-operative value, indicating the clinical stabilization of disease. Additional outcome including the VCVA along with the CCT, apex pachy, and specular microscopy. And statistical analysis was done by Wilcoxon sign rank test. And these are the demographic indices. The BCVA was which there is no significant drop in the BCVA as compared to the pre-CXL and the post-CXL of the combined epi-off procedure. And it is our practical observation that 37% patients showing there's a one-line improvement, and the 29% patients showing there is a remain the visual stable, and across 32% patient the worsen after the drop of one more than one line. Thinness pachymetry, there is no significant improvement. The drop in the thinness pachymetry, topo K, and the posterior elevation values, and the central corneal thickness also remain the stable. So on discussion, standard CXL technique cannot be applied in thin cornea for the UV-related toxicity of the endothelium and the H1CXL already proven procedure. While several modifications have been proposed, there is no standardized procedure for the treatment for the thin cornea. In our study, we used isodium riboflavin 0.1% with a 1.1% HPMC as a carrier. The wow factor of the study is that it's combined epi-on and epi-off procedure, and epi defects resolve very fast and immediate post-op, less symptomatic. The recovery of the recovery vision early, the halting the progression efficiency and compared to the halting the PMC CXL. So these are our study relevant. This is our study compared to the relevant study. So these are the real time picture that no showing that there is no significant changes in the posterior elevation and the thinness pachymetry and the your topo value. So on conclusion, isosmolar riboflavin HPMC is a safe and a sustained surgical technique for thin cornea where the pachymetry less than 400 pachy, halting the progression. At the end of the 6-month post-CXL, we found no significant changes in the reduction of CCT and thinness pachymetry and posterior elevation. KM reading show the standards after the CXL with topo K value show the almost one after regression in post-CXL eyes. VCB remained stable at the end of 6 months post-CXL eyes. In addition, advantage in the study over the only HPMC CXL. Further studies with a larger sample and the longer follow-up are upcoming to assess the efficacy before the procedure is applied for the large cohort of patients. Thank you. Thanks for your patience hearing.
Thank you very much. We want discussant Dr. Madhukar,
Yeah.
and next is Dr. Sanjay.
Yeah,
Yes, sir.
Dr. Sarkar, one thing is in the central area when you are leaving the epithelium on, that's where the cross-linking is not occurring, which is one of the disadvantages. There is another nomogram where you remove the epithelium but use lesser amount of the UV exposure time. So that also is a good technique, and you can use that wherein the collagen cross-linking is done uniformly. You can consider that technique also.
May I, sir? With
Yeah,
due respect, sir.
yeah, go ahead.
It's actually the thing is that I have seen this study. The concept has come. I have seen one of the best video in the ACRS 2017 in Paris. So really, I very much, I mean, like that procedure, and I have started just after that. But meanwhile, there is a COVID was there. So my cohort of patient almost 40 eyes. Already it's proven that there is a AP on and AP off at the end. It was almost same effects. So why not we combine this procedure? And once I do the ASOCT after 3 months, and we can exactly again the top head same. So it indicate that the procedure is sufficient enough to halting the progression, and which is supposed by the other topographic indices, because all showing there is no any regression. I mean the k value change, whatever the progression we know, the values parameters in the topography indices as well as clinically. So whatever we are judging, the thinnest packy, posture elevation, and the topo K, and subjective freshen on all respects, it's showing the stabilization. And even not only the central islands, some of the patients, thus we can modify. You can make the raster pattern also, sir. Even I have done the raster pattern also.
Yeah, I agree.
So,
There are many ways to skin a cat,
yeah,
and this is one technique. We appreciate a technique, but
yeah.
I'm expressing my reservations.
Okay.
But time will tell. Thank you.
Thank you, sir. Thank you very much.
Ask you a question, please. You have left the
Yes, sir.
central area epion,
Yes, sir.
but the thinnest area is
No,
never in the center.
yeah. No, we are actually the most of the time we are in the thinnest packet. Either we in the central. If it is suppose the thinnest one, I try to be preserve the epithelium in the thinnest packet one. The not on exactly the pupillary all time. So whenever the if it is not correspond to the pupillary zone, so we little bit of enlarge the things, but it is not the criteria that all time we have to involve the visual axis. It's mainly the thinnest pachymetrium, islands of the thinnest pachymetrium.
One definite advantage of this is what we have seen is that it doesn't produce a haze in the central area.
Yeah, that is one of the thing, but we will get the same ASOC if we do the ASOC all the cases routinely after the 3 months, and we'll get the same top hat pattern. So indicate that your CXL it is not discontinuation. It is uniform top hat pattern. So it indicates that this procedure your halting of the progression is there. You can get the demarcation line, sir. Yes, sir. Thank you very
Agreed.
much.
Wonderful.
Thank you
Thanks.
very much, sir.
Shall now go on to our next speaker, Dr. What has he? So sorry. Dr. Sanjay Chaudhary. Invite Dr. Sanjay Chaudhary. You have already spoken, no?
No,
Oh,
no.
there was a
Chitra,
confusion here.
you worked so hard in this conference. It's
No,
showing.
no, no. We had gone to the next sessions actually mentally, judges and all that, who has come and all. So he's going to talk on bandage contact lens, scaffold for the management of PCR with residual nucleus. And we have Dr. Mayuri Kamar. I'm so glad that the election is over. With this slip of mine, some of you wouldn't vote for me.
Okay, thank you so much. So I'm talking about a contact lens scaffold in a PCR with residual nucleus.
दूसरा paper.
As you see this video, you have to keep three things in mind. Sorry. As you see this video, so sorry. As you see this video, you have to keep three things in mind. So far, the technology promoted was an IOL scaffold for PCR with residual nucleus. We were doing IOL scaffolds, but the three problems we found in that technique. One, the lens was thicker in the center, so the AC was shallow, and when you were doing the nucleus pieces removal, you were very close to the endothelium, so there was endothelial cell loss. Two, the IOL once inside the eye had to be positioned into the bag or the sulcus. That means your access to the epinuclear material and the cortex was limited, and many a times you had to leave that matter behind because you couldn't pick up the whole thing outside. Right? So we devised a system where you could first have a scaffold, take it out, and then remove the epinucleus and the cortex. So with these things in mind, just watch the video. Can you start it from the beginning, please? I haven't started it yet. Okay, so you see these large nuclear pieces. The PCR is already there. The vitreous is already there. I'm cutting the vitreous strands so there's no traction. The best way is you pick up each strand with your left hand, and for that you need 3 hands actually. One hand is being covered by the ACM. So your 2 hands are free and you can comfortably go around tracking each vitreous strand and cutting it. Now this is the contact lens scaffold. The size is 9.5 millimeters. We worked through several models, 10 millimeters, 9.5, 9, and we decided that 9 is the best comfortable size. 10 becomes too big, 9 becomes a little smaller, and there's a risk that it will not hold on the iris and fall into the vitreous. So you need a support. Now you just inject it with any IOL injector and open it up, concave surface up, and direct these nuclear pieces on the concavity of the contact lens. Why a bandage contact lens? Because it is thicker. The central area is 100 microns. Normal contact lenses are thinner. They could collapse and fall into the vitreous. So you needed a thicker contact lens. So the nuclear pieces are guided over this contact lens. It is opened out on the iris. You bring the nuclear pieces in and at ease emulsify them without fear that these pieces will fall in the vitreous cavity. So emulsified. Now the main job done. Now I'm trying to bring out these thick epinuclear pieces because this was a hard cataract. I could do that afterwards, but I'm doing it before also. So I'm bringing out the whole epinuclear girdle from the under the contact lens to the side over the contact lens. Something you cannot do in an IOL scaffold. Bring it up, comfortably emulsify it. Second hurdle gone. Now there's all that PCR and the cortex, and I don't need an obstruction like an ICL in the system, so I just hold it and pick it out. It's just so simple. Now this whole area is open before me. I use a retractor for irrigation, aspiration and cutting. So in the IA mode, I hold the cortex, bring it to the center. In foot paddle 3, I activate the retractor and that cuts the cortex along with any attached vitreous strands. So I'm removing the attached vitreous along with the cortex, and everything is coming out so smoothly. There is no falling of these cortical matters in the vitreous cavity. There are no strands which are vitreous strands which are coming in my way and causing a tug, and have a total, complete, smooth cleanup. Everything looks as if it was so simple. And now is my time to go in with an IOL. I'm doing a sulcus fixated. In it goes. And because it is sulcus fixated, I do an optic capture. So this is the optic capture. Thank you so much.
Thank you. Thank you very much. We go on to Dr. Mayur.
Congratulations for the nice video and the good concept.
Thank you, ma'am.
But I'm little uncertain whether you can hold the contact lens can hold the high pressure of the and vacuum that you are
Yes,
doing.
ma'am. So we don't work at a bottle height of 110. We are working at an IOP of 40.
Okay.
So that pressure is not there.
Not there.
So I use the Centurion system with a fixed IOP, or my other colleagues who don't have this system, they have a bottle height, so they work at a bottle height of 70.
In that case, it might dislocate.
Very high pressure, the pressure will be too high, even that can collapse inside.
Yes.
Because what is holding is just the iris, and iris is very flimsy.
Do you constrict the iris or it is just like that?
I do what?
Meiosis? You
No,
induce,
no, because if I do a meiosis, I may not get a dilation later on to remove my cortex.
Okay. It was a nice concept.
Thank you. Thank you so much.
Any endothelial cell count was
Sorry?
endothelial cell count?
Yeah. So when I did my IOLs as a scaffold, the cell loss was almost 30-35%. But in this, the cell loss was 15%.
Yeah, I'll also go.
So I saved
Yeah.
20%.
I invite the next speaker. Thank you very much, Dr. Sanjay.
Thank you,
Dr.
ma'am.
Narendra Singh Verma, and he's going to talk on an easy and complete toric solution. And I have Dr. Suresh Kumar, who's going to be discussing. Just wait. Anagha, can you be here?
Good morning.
Sorry, I have to leave for the national symposium. And I know each and every judge here came because I had called them. And I'm so deeply, please, 1 minute, Dr. Sanjay. Dr. Sanjay, please. I'm very, very thankful to all the judges for coming here for my sake. And I'm deeply obliged to all of you. So please mark the thing and Anaga will collect it from you. Thank you.
Good morning, everyone, seniors and respected judges.
Of course, I need it.
So,
upper GIT on
can I start? So,
Please
I
do.
start my presentation, Easy Tour. आगे नहीं जा रहा.
Funny way of expression.
So during cataract surgery, there are two ways to decrease the corneal toricity. Either you have to implant the toric lens or you have to take the incision on the steep axis. So the surgical problem is there is error in the marking of the steep axis and marking of the axis of alignment. Presently, there is no solution which is economical, easy and error-free. I present you innovative surgical solution EasyTor. So EasyTor has all important features which are required for preoperative workup and intraoperatively to mark the steep axis and axis of alignment of the toric lens. So for preoperative workup, we want topography, keratometer reading in 3, 5 and 7 millimeter zone, axial heat map, the nature of astigmatism should be regular. For the toric lens, it has manual image guided system. It is based on the principle of image guided system. So it provides easy and error-free marking of axis of alignment. For surgical correction of astigmatism by incision, it has SCA module for easy and error-free steep axis marking. It is also having a new feature for the first time. It is having direct access to Barrett toric calculator and Barrett universal 2 formula. So it is very fast and prevent transcription error. By one click of button, you can get directly the net astigmatism and axis of alignment from Barrett toric calculator directly. Let's see how it works.
It is a topographer with many additional features. It provides an easy, efficient, and economical alternative to existing solutions. It is an LED-based anterior surface topographer which analyzes 600 data points in a 9mm central corneal zone. A single capture provides us with all the required data which is summarized on a single screen. It provides keratometry in 3, 5, and 7mm zones, axial heat map, wide to wide, etc. Demonstration of toric lens axis alignment. Left eye keratometry of this patient shows 1.5 diopter astigmatism in 132 degrees in 3mm zone. Press the calculator icon. Net astigmatism will be displayed directly from Barrett toric calculator. It is 1.1 diopter in 145 degrees in this case. Enter SIA value, which is 0.3 in this case. The axis of alignment will be displayed automatically, which is at 147 degrees in this case. Press the pencil icon to enter biometry data. Axial length, ACD, and lens thickness. The axis of alignment at 147 degrees is displayed as a green line and site of incision at 136 degrees in the form of a pink highlighted area. Identify two prominent limbal structures. Click on it. The system will display their axis. It is 17 and 50 degrees in this case. Save the picture, rotate it as needed, and use it intraoperatively to identify landmark points under microscope. Here I am making two landmark points at 17 and 50 degrees on the patient's eye. Hold the degree gauge and align it with the markings. Now mark the site of incision which is at 136 degrees. After lens implantation and viscoelastic removal, bring the degree gauge again to mark axis of alignment on the limbus at 145 degrees using 17 and 50 degree landmark points as reference. You can also mark the axis of alignment on the cornea. Finally, align the toric lens axis with the corneal markings. SCA marking module can be used for surgical correction of astigmatism using incision as a plan B in patients not suitable for toric lens implantation. Demonstration. Right eye is pseudophakic and post-op residual refractive error is plus 1.5 spherical with minus 3.25 cylinder. Even though the IOL power was perfect, the site of incision was incorrect as it was on flat axis. The left eye has cataract with 1.1 diopter cylinder at 175 degrees. Press the pencil icon to enter biometry data in Barrett Universal 2 formula. Then click the calculator icon to get IOL power options with residual refractive error. I planned for 5.5 mm main incision at 175 degrees and 2.8 mm OCCI to neutralize the 1.1 diopter astigmatism by using incision. Identify and mark two prominent limbal structures which are at 14 and 168 degree in this case. Intraoperatively mark the same points on the limbus using marker. Using these landmark points as reference, I mark the site of incision at 175 degrees on both sides. After lens implantation, a 2.8 mm OCCI was done and the main incision was extended to 5.5 mm. These are post-op day 1 and day 6 pictures.
So we developed this topographer in last 3 years, and it is having some different apps.
Very nice presentation. Who is the discussant? Anybody can comment.
Can comment.
Yeah, anybody can comment. So what were the advantages that you had over, say, Verion or?
It is on the same principle.
Of course,
it
the
will be
cost.
very economical.
Yes, it's cost-wise.
Yeah. So it will be
But
very
it doesn't
economical.
have image guidance. It
Yeah,
has
it
to
has
be
image
economical.
guidance.
It doesn't have image guidance. You are marking.
That is not there. That is there. We will also implement that. That will be also possible. And actually, I am writing manual image guided system. We have to do one manual marking just after putting the toric lens. You see where the landmark structure. You mark the landmark structure. They are the reference point. From there, you can do one manual marking. So it is not totally image guided system. It is manual image guided system. So one manual pre-operative manual marking is not required, which is very problematic for the surgeon and for the patient. So pre-operative marking are not required. So only
There are two things that I actually failed to understand. One was why do you need a keratometry at 5 millimeters and 7 millimeter
so
zones?
it is also because regularity you can find out how much regular cornea
So
is there.
that is topography. Why would you need a keratometry at 5 and 7 millimeters?
So it is a keratometer is giving you. We want only 3 millimeter, but we can find out how much axis is changing. So for this corneal should be regular if you want to put the toric lens, or if you want to take the incision on the SCP axis, that corneal should be regular. So we can find out just it is provided.
And the other is the surgical video that you showed. What made you say that that patient was unsuitable for toric implant?
No. If the patient, some patient they can't afford. Some patient are unsuitable. That though if plan B is also there, if the patient can't afford, I can.
So the plan B in here was
Not if plan B means it should be that if patient is not suitable means he can't afford, or sometime we are not able to put the lens. We are not having the lens and any condition.
and you extended the section to 5.5 clear corneal and 2.8 on the other side.
Yeah, but I am making that main tunnel. I am making it longer tunnel, so it is easy.
Are you sure it is not going to add on to the astigmatic value if you're making a longer tunnel?
But AC, I am putting the air, and it is not on the tropical. I am retrobulbar, and I am doing patch for 12 hours.
Okay.
What would be the SIA for that 5.5 millimeters? Because the SIA also been changing.
That goes up to 2. The regression will be there.
That will depend on the length of the incision also, sir. That's what I'm saying. Since you said that you're elongating the section, I don't know how you're doing it post-operatively, but if you are doing it, then it will have additional flattening effect and it will be unpredictable because we don't have anything published as of now to know how much astigmatism that incision per se will cause.
Actually, we are having Boramani. We take the data from Dr. Boramani sir and made a nomogram. It was just for presentation that for by incision you can correct the toricity of the cornea if you are not having the patient can't afford for the toric lens. That is the only thing.
Can you just explain the transportation of the image taken by the topographer to the OT?
So it is Wi-Fi assisted. So when your optometrist examine the patient, you can access this from with the Wi-Fi in your. You can access this on your PC or whatever is tablet in your room, OPD room. So then you can see what are the results, and you can also analyze the results from there. So it is in the OT also. Sometimes what happened in the OT, you are operating, there is chemosis, conjunctival hemorrhage. The landmark point which you have marked are not visible. So you switch on the machine, you take the tablet in the OT, then whatever structure are visible in the eye, you can, whatever in the topography picture, you can again click. So whatever structure is visible, you can find out what is the position of these structures. So
basically it is, what I see from the whole thing is basically it is actually the same as the Osher's alignment that is there even on a night race.
Yeah.
You have to find out anatomical landmarks, but you know, we know that they are not very well defined when it comes to.
We use this 12 megapixel camera. Now we shifted to 64 megapixel. So camera quality will go on increasing. So we'll get very good picture in which we will able to see iris structures also. So that will future is there. So
what is the cost of this?
we were planning to use this, launch this, but we stopped because now we are working on the 64 megapixel camera. Second, we are also doing P2 by infrared. So total K will be there. You can get how much is the net estimate from the Barrett and how much is your total K. Third, non-invasive tear film breakup time. So presently it is manual. It is providing you pictures every second. So you can see in which area the picture are blurred. So which spreads, the LED light reflection is spread. So you can find out where the.
No, sir, I wanted to know what is the cost and how much cost effective it would be.
Five will be the cost. With the, if you want for the P2 also, total TK and the tear film, it will be more. So yeah, 5 lakhs.
Thank you so much. Thank you. I think we have finished with all the presentations. I would like to thank all the expert panelists for sparing their valuable time. Let's have a picture with all of us here. Come, sir.
Hello one and all. This video is also cost effective. So let me run you through one of the cases. So this is a case of a 50-year-old male who had a blunt trauma and a secondary subluxated cataract. So here 3 localized peritomies have been made and a 25 gauge system is used.